Welcome to the Deep Dive. Today we're looking into skeletal muscle relaxants.
Right.
It's fascinating when you think about it, how our muscles just work, how they relax, something we barely notice.
We really take it for granted, don't we? But the science behind it and how these drugs interact, it's quite something.
Absolutely. And the sources you sent over, they cover a lot of ground, from the tiny cellular stuff to, big medical procedures.
Yeah, they really do. It shows just how important these agents are in medicine today.
So our mission then is to kind of unpack all of that, pull out the key bits about these relaxants, how they're classed, how they work, where we use them, and the potential downsides too, of course.
Sounds like a plan. Where should we start?
Well, maybe with the basics. Before we talk about relaxing muscles, how do they normally contract? What's the normal sequence?
Good idea. Okay, so it starts with a nerve impulse, right? A signal traveling down a nerve.
Okay.
And when it reaches the end, where the nerve meets the muscle, that's the neuromuscular junction, the NMJ.
Communication point.
Exactly. The nerve releases a chemical, acetylcholine, A for short.
ASU, got it. The messenger.
Right. And this ACU then floats across that tiny gap and binds to specific spots on the muscle cell surface. These are called nicotinic receptors.
So it docks there.
It docks there. And that docking action, it flips a switch, basically. It opens channels, letting sodium ions rush into the muscle cell.
Sodium ions. Positive charge.
Positive charge, exactly. So the inside of the cell becomes less negative. That's called depolarization.
Depolarization.
Yeah.
And that leads to the contraction.
Pretty much. That depolarization triggers what's called a muscle action potential. Think of it like an electrical wave spreading along the muscle,
Right.
telling it to contract.
Okay. Nerve signal, A sheet release, docking, sodium rush, depolarization, action potential, then contraction. Quite a chain reaction.
It is a very rapid one.
So what stops it? How does the muscle relax again?
Well, that's where another player comes in.
Yeah.
An enzyme called cholinesterase.
Cholinesterase.
Yeah. It lives right there in the junction, and its job is to break down the ACA almost immediately.
It cleans it up.
It cleans it up fast. So the receptors become free again, the sodium influx stops, the muscle cell goes back to its resting electrical state, repolarization.
And relaxes.
So you can
at-
see why that neuromuscular junction is such a key target for a lot of these relaxant drugs.
Makes perfect sense. Okay, so that's the normal process. Now let's get into the relaxants themselves. How are they, grouped or categorized?
Generally, we divide them based on where they act. So you've got centrally acting ones.
Working on the brain and spine.
Exactly. Then peripherally acting ones, working more at the muscle or the NMJ itself.
Okay.
And finally, direct acting relaxants.
Direct acting, so straight onto the muscle tissue.
Pretty much, yeah. Bypassing the nerve communication to some extent.
Could you maybe give us a quick analogy, just to sort of picture the difference?
Sure. Think of the centrally acting ones, like sending calming signals down from headquarters, the brain, telling the muscles further down the line to ease off.
Okay, top-down approach.
Right. Peripherally acting is more like interfering with the communication right at the muscle site, or maybe blocking the phone lines at the NMJ.
Gotcha. Cutting off the message locally.
And the direct acting ones, they're like going inside the muscle factory itself and, switching off some of the machinery directly.
That helps. So examples. What drugs fall into these categories? Centrally acting first.
Okay, centrally acting. You've got benzodiazepines, like diazepam. They work a lot with GABA, the brain's main sort of inhibitory neurotransmitter.
Calming chemical.
Right. Then there's baclofen, also GABA related, and tizanidine, which hits different receptors, alpha-2 receptors, also in the central nervous system. These are often for spasticity.
Right, chronic muscle tightness.
Yeah.
And the peripheral ones.
So peripherally acting, these are split again. You have depolarizing agents and non-depolarizing agents.
Depolarizing and non-depolarizing.
Yeah. The main depolarizing one everyone learns about is succinylcholine.
Acetylcholine.
And for non-depolarizing, there are quite a few. An older one is ditubocurin, but more common now are rocuronium and vecuronium.
Rocuronium, vecuronium. Heard of those?
Yeah, used a lot in anesthesia.
And the direct acting category.
Two main ones there. Dantrolene, which messes with calcium release inside the muscle cell.
Calcium's needed for contraction, right?
Absolutely. Less calcium release, less contraction. And the other is botulinum toxin.
Botox.
Yeah, that's the one. It works differently, though. It stops the nerve from releasing esci in the first place, right at the NMJ.
Okay, that's a great map of the territory. Let's maybe zoom in on succinylcholine first. The depolarizing one. You said it has a unique mechanism, 2 phases.
It really does. It's fascinating, actually. So phase I SC binds to those same nicotinic receptors as SC.
Okay.
But unlike SC, it isn't broken down quickly by cholinesterase, so it hangs around, keeps the receptor activated, and causes this prolonged depolarization.
Prolonged depolarization. But doesn't that cause contraction?
Exactly. Initially, it does. It causes these brief, uncontrolled muscle twitches. They're called fasciculations. You can sometimes see them.
So it makes the muscle twitch before it relaxes it. That seems backward.
It does seem odd, doesn't it? That's phase 1. Then comes phase 2.
Okay.
After that initial prolonged depolarization, the muscle membrane sort of gets tired. It becomes desensitized. Even though SHME might still be there, the receptor stops responding properly.
So it wears itself out in a way.
Kind of, yeah. And that leads to the paralysis, the relaxation, flaccid paralysis.
Wow. Okay.
Yeah.
And it acts really fast but wears off quickly, like 3 to 8 minutes.
Super fast onset, which is why it's useful. And yes, short duration. That's because of a different enzyme found in the blood plasma called pseudocholinesterase.
Pseudocholinesterase.
Yeah, plasma cholinesterase. It breaks down ESH pretty rapidly.
Which makes it good for quick procedures, like putting in a breathing tube, intubation.
Exactly. Its speed is its major advantage there.
But that weird mechanism, it must have some downsides, adverse effects.
It definitely does. Those initial fasciculations, they can actually cause muscle soreness afterwards.
Okay. Makes sense.
Also, because it messes with ion flow, it can cause potassium levels in the blood to rise hyperkalemia. That's a worry in some patients, like those with burns or kidney problems.
Right.
It can also briefly increase pressure inside the eye. And the big one in susceptible people is malignant hyperthermia.
Malignant hyperthermia.
That sounds serious.
It's very serious. A rare genetic thing. But SV can trigger this massive, uncontrolled metabolic reaction in the muscles, soaring temperature. It's a life-threatening emergency.
Wow.
And one more thing, remember that pseudocholinesterase enzyme that breaks it down?
Yep.
Some people have a deficiency. They don't make enough of it, or it doesn't work properly.
So the drug hangs around longer.
Much longer. So instead of a few minutes of paralysis, they might not be able to breathe on their own for, hours. Prolonged apnea. They need to stay on a ventilator. Okay, so definitely a drug to use with caution. Let's switch gears to the non-depolarizing ones. Rocuronium, vicuronium. You said they're competitive.
That's right. They compete with Axio for those parking spots, the nicotinic receptors at the NMJ.
They don't activate the receptor.
Correct. They just sit there, block Axio from binding, so no depolarization happens, no contraction. It leads to flaccid paralysis, but without that initial twitching phase you see with XC.
Simpler mechanism then.
And reversible.
Yes, that's a key difference. Because it's competition, if you can increase the amount of AXI at the junction, AXI can eventually win back the receptors.
How do you do that? Increase AXI?
We use drugs called anticholinesterases, like neostigmine. Remember, cholinesterase breaks down AXI.
Yeah.
Well, anticholinesterases inhibit that enzyme. So AXI doesn't get broken down as quickly, its levels rise.
And it outcompetes the blocker.
Exactly. It overcomes the blockade. We usually give something like atropine alongside neostigmine, though, to block some of its other unwanted effects elsewhere in the body. Okay. And these non-depolarizers, they come in different durations, too. Long, intermediate, short.
They do. Pancuronium is longer acting. Vecuronium, rocuronium are intermediate, very commonly used. Mevacurium is shorter acting.
Does it matter much beyond just the timing?
It can. Some have slightly different side effect profiles. Pancuronium, for example, can increase heart rate, a vagolytic effect.
Okay.
Vecuronium is often highlighted because it generally doesn't cause histamine release.
Histamine. Like allergic reactions?
Yeah, histamine release can cause things like flushing, a drop in blood pressure, even bronchospasm in some people. So avoiding that can be good.
But mevacurium can cause it.
Mevacurium, the shorter one, is more associated with histamine release sometimes. So you pick the drug based on the procedure length, patient factors, potential side effects.
Makes sense. And the main risks with this whole group, non-polarizers.
Well, the biggest risk is inherent in what they do. They paralyze muscles, including the breathing muscles.
Respiratory paralysis.
Absolutely. So anyone getting these must have their breathing controlled, usually with a ventilator. And things like hypotension, the drop in blood pressure, or bronchospasm are possible, especially if there's histamine release. Careful monitoring is key.
Right. So we've got these different tools. Where do they actually get used clinically?
Oh, all over. Surgery is a massive one. Getting good muscle relaxation makes the surgeon's job much easier, safer sometimes. Vecuronium, rocuronium are staples there.
And SC for the quick intubation.
Exactly. Rapid sequence intubation. When you need that airway secured now.
What about outside the OR?
Well, controlling severe muscle spasms like in tetanus or sometimes during status epilepticus, those prolonged seizures.
Hey.
And remember, malignant hyperthermia triggered by
Yeah,
SU.
a scary one.
The specific treatment for that is intravenous dantrolene, that direct-acting relaxant.
So one relaxant used to treat a crisis caused by another. Interesting.
It is. Dantrolene is life-saving there. Also, for chronic spasticity, maybe after spinal cord injury or in MS, baclofen or tizanidine, those central ones, or even botulinum toxin injections can help manage stiffness.
And Botox for wrinkles, the cosmetic use.
Can't forget that one. Same drug, different application, tiny doses to relax specific facial muscles.
It's quite a range, from life-saving interventions to cosmetics.
Okay, reversal. We talked about neostigmatin for the non-depolarizers, but you mentioned a newer drug, Sugammadex.
Ah, yes, Sugammadex. It's pretty clever. A real step forward for reversing rocuronium and vecuronium specifically.
How's it different? Not just boosting ASIAN.
Not at all. It works completely differently. Imagine like a donut-shaped molecule, a cyclodextrin. Sugammadex is designed to perfectly encapsulate or trap molecules of rocuronium or vecuronium.
Like a molecular cage.
Exactly. It binds directly to the relaxant drug itself in the plasma and at the NMJ, effectively pulling it out of action.
It just mops it up, pretty much. Which means reversal can be much faster and more complete than with neostigmine, especially if the block is quite deep.
That sounds like a big deal for recovery after anesthesia.
It really can be.
Yeah.
Faster wake-ups, faster return of muscle strength, potentially less time in the recovery room. It's changed practice quite a bit.
Very neat. Okay, winding down a bit.
Hmm.
General side effects or interactions to be aware of across the board.
Well, for the centrally acting ones, think sedation, drowsiness, dizziness, CNS effects.
Right.
For the peripheral ones, we've hit the main ones. Potential for hypotension, the absolute need for ventilation due to apnea, and histamine release with some.
And drug interactions.
Yeah, a few key ones. Certain antibiotics, the aminoglycosides like gentamicin, can actually make the blockade worse, make it last longer.
Good to know.
Low potassium levels, hypokalemia also enhance the effect of non-depolarizers. And some of the gases used for anesthesia, the inhalational agents, can also prolong the block. Lots of things for the anesthesiologist to juggle.
Definitely sounds complex. And finally, you mentioned a few special situations, things requiring extra care.
Right. We covered malignant hyperthermia, SC, and certain gases as triggers, dantrolene as the treatment. Crucial to recognize and treat fast.
Okay.
Then there's myasthenia gravis. That's an autoimmune disease affecting the NMJ receptors.
Right.
Patients with MG are often very sensitive to non-depolarizing blockers. They need much smaller doses, very careful titration.
Makes sense. The receptors are already compromised.
Exactly. And we also talked about the pseudocholinesterase deficiency.
Leading to prolonged paralysis after succinylcholine.
Right. Requiring ventilation, sometimes for hours until it wears off naturally. You need to be prepared for that possibility.
It really highlights how individualized medicine needs to be, doesn't it?
Yeah.
Especially with potent drugs like these.
Absolutely. One size definitely doesn't fit all.
So wrapping this up, it's clear these skeletal muscle relaxants are, well, a really diverse toolkit. Different mechanisms, different targets along that whole nerve-to-muscle pathway, essential in surgery, critical care, managing chronic conditions, even, smoothing wrinkles.
Couldn't have surgery as we know it without them, really. But yeah, powerful tools that need respect.
Absolutely.
Yeah.
The potential side effects, the interactions, the need for ventilation.
Yeah.
It all requires real expertise.
It really underscores the complexity of managing something that seems so simple, just relaxing a muscle.
Yeah, it makes you think, doesn't it? About that whole intricate balance, contraction, relaxation, this precise chemical dance happening constantly.
It does.
Kind of leaves you wondering, what other automatic things our bodies do are run by such fine-tuned chemical signals? And what happens when those signals get disrupted? There's just so much going on under the surface.
A lot to ponder, for sure. The hidden complexity is everywhere.
Well, this has been a fascinating deep dive. Thanks for walking us through it.
My pleasure. Always interesting stuff.